Okay, it seems that we can start now. So thank you again for joining me today. My name is Cláudia. I'm a biomedical engineer from Sensing Future. I work mainly in the innovation and scientific development of PhysioSensing, as most of you know. Uh, Today, we are going to talk a bit about limits of stability. So here in Sensing Future, we are specialists in technology for force and pressure platforms with wide applications in physical and vestibular rehabilitation, as you saw in previous webinars. And today we are going to focus on limits of stability. So let's start here with the summary to show you. Okay, so first we are going to talk a bit about how to perform the protocol, how it should be done. Then we are going to explain all the measures that are calculated and what they mean. And in the end, we'll go into a few clinical considerations about the limits of stability. But before, let's talk a bit about balance. If you saw previous webinars, I always like to talk a bit about what is balance. So balance is the ability to maintain the body center of mass over its base of support. As you can see here in this image, we have here the center of mass is usually in this area for the human body. And here you have the center of pressure, which is the projection of the center of mass on the support surface, representing how the acting force on the plantar surface. This is the physical foundation of instrumented platforms, either force or pressure, which obtain this golden measure, the center of pressure. When the COP is over the base of support, as you can see here, a person's body gets unstable and may fall. But how balance works? Balance is achieved and maintained by a complex set of sensory motor control systems that include sensory input from vision, such sight, proprioceptions, with touch, muscle joints, and the vestibular system, the motion, the equilibrium, the spatial orientation, which is then sent to the brainstem, as you can see here in this image. Then we have the integration of all these inputs in the cerebellum, where we provide and integrate it with learned information in the cerebral cortex. The cerebellum provides information about automatic movements that have been learned through repeated exposure to certain motions. For example, I always talk about this example. When we repeat practice serving a ball, a tennis player, for example, he learns to optimize the balance during the movement, and sensory integration takes place, and the brainstem transmits impulse to the muscles that control the movement of the eyes, the head, neck, trunk, and legs, allowing the tennis player to both maintain balance and have clear vision while moving. So when any of these systems is injured or deficient, balance can be markedly affected. So now that we understand a bit more about balance, let's have a look at the limits of stability protocol. So how it is performed? This protocol is perhaps the most used protocol in the literature for balance assessment in the dynamic task. In this case, the patient is not in the static position. They need to lean towards the target. So it quantifies the ability to intentionally displace the center of pressure to the limits of stability of the patient without losing balance. So if you take a look at this, I have here the pencil. So if you try to lean in your limits of stability, you can see this is the position that the human body should do in a static, in a rigid upright position without moving their shoulders, their hips, and this is the idea of this protocol. So they must reach 8 different directions, as you can see in this video. I'm going to stop the video to show it more. Okay, you can see here the 8 directions. So we have front, we have forward right, right, backward right, backwards, and then backwards left, and left and forward left. So these are the 8 directions that we measure in this protocol, and they must try to reach the points using their center of pressure. The center of pressure of the patient is this blue point that we see here in the video. Is trying to reach the points, and First, he must hold in the center. Let me go again here in the center, and when the target, I don't think you can see it very well here, but we have an outline target in orange. This is the next target. They must move to the target when they hear a beep or they see that the target is now orange, as you can see here. So it goes orange and the patient needs to try and reach the position. They must move as quickly and as straight as possible without losing balance. For each direction, we have a timer countdown of 8 seconds, and in the end, they must return to the center position. They need to repeat for the 8 directions. And this distance that I have been talking about, the limits of stability, they are calculated according to this famous cone that we have here, that are according to the height of the patient's center of gravity. So a taller person will have larger limits of stability. These distances are calculated for 100% of the theoretical limits of stability. This means 8 degrees to the front, 8 degrees to the left, to the right, and 4.5 to the back. Like I've told you, during the leaning movement, the patient should be straight and without losing the balance in the comfortable stance, and they cannot do rotations or hip movements. And if they cannot reach the point, the target, they need to stay and maintain in that reach position until the timer ends. So this is how it should be done. In the end, this is what it looks like after performing the 8 directions. We show the trace of the center of pressure as well as all these values. So this is just to give you a global view of the results. So now let's understand the meaning of each one. So the first one is the COP that we talk. It is known that the body sway can be translated into center of pressure, like I've told you before, in mediolateral and anteroposterior directions. So when you sway, we can get the mediolateral displacements and the anteroposterior displacement between each point. And this allows us to get a graph like this in the right side. And we then analyze all these center of pressure values to calculate different metrics. So the metrics that we have in this protocol, the first one, again, just to show you the limits of stability, we need to reach all the 8 directions according to the cone. And the first that we have is reaction time. The reaction time, I'm just going to show you an example for this direction, the right forward. This is a bit larger so that you can see better. The reaction time is the time between the indication to move and the first movement of the patient in seconds. So when we start the countdown, we have 2 seconds between the start button and the orange target. So when it moves, when it goes to orange, we calculate the time that the patient took to start the movement. Then we have the endpoint exclusion. This is the distance from the first attempt to reach the orange target, expressed as a percentage of limits of stability. The orange point, like I've told you, is at 100 limits of stability, and then we see how much the patient did in the first distance. The first distance is considered, the first attempt, the point at which the initial movement towards the goal ceases. So when the patient slows down, like you can see here in this example, it will be more or less in this zone, in this case at about 70% of the limits of stability of the patient. Then we have the maximum exclusion, is the maximum distance reached during the 8 seconds trial, again expressed as a percentage of limits of stability. In this case, it is about 19%. As you can see, it was a bit larger than the endpoint exclusion. Then we have the movement velocity. In this case, is the normal velocity that we all know. So it's the distance traveled by the center of pressure divided by the time. But in this case, we only use between the 5 and 95% of the first attempt, which means of the endpoint exclusion, we see how much it is, 5 and 95%, and then we calculate the velocity between each point, as you can see here, and we calculate the variation of displacement between each one and the variation of time between which one to calculate the velocity. Then the last parameter that we calculate, we have the directional control. This one, as you can see, it's the percentage of movement in the intended direction minus off-axis movement during the first attempt. So we have here, let me show you the pointer. So we have here the indication of the perfect displacement to this direction. And if you see here, there is a deviation, in this case, a bit to the left. And what we calculate is the percentage that is off axis. So until the first attempt. The first attempt, again, is the endpoint exclusion that was here. So then we come here and we calculate this deviation that the patient did. In this case, in this example, is about a directional control of 88%. If you have a lot of zigzag line, or if you go way over of the direction that we wanted, then you will have 0% in the directional control. So these are the parameters that we calculate in the limits of stability. And again, we have this interface just to show you. This is what you can get with this protocol. But then we show you the results like this in our interface, because we calculate the average for each Cartesian axis, for the front, for the back. If you look at here, it is very small: front, back, right, left. And then we have the composite, which is the average of all directions that you see here. This is presented along with normative data for the patient age, as you can see here. In this example, you have everything green, so it means that the patient is inside the normative data for all the parameters. In case the patient has results outside the normative values, the bar will appear red. In the graphs, you can see here this line. It is the representation of the normative data for the patient age, and the white zone is the normative data. In the end, after having all this information, you can export quickly to a PDF file that you can print, and you can also view the progress between evaluations. I have here an example. So you can see all the sessions that the patient did. In this case, we have 3 sessions, and you can see the results that the patient did on each session for each parameter. And we can also compare the first session and the last session. And here again, we have the normative value for the patient and how much the percentage of improvement the patient had for each parameter and for each direction, again, front, back, left, right, and composite values. So this allows a more objective and quantitative look at the patient performance during a dynamic task. And it is also important that using protocols like this in PhysioSensing, it allows you to have objective measurements that are reproducible, practical, and reliable, allowing comparison and progress monitoring after rehabilitation, for example. So now that we are more in depth about the results of limits of stability, let's move on to the clinical considerations. With this protocol, it is possible to assess the voluntary motor function being appropriate for patients with central nervous system pathologies and peripheral neuropathic disorders, older adults with mobility impairments, and athletes interested in rapid reactions and direction change. The ability to voluntarily move the center of pressure within limits of stability boundaries is fundamental for several functional tasks associated with activities of daily living. Thus, results outside the normative values can be representative of value of voluntary motor impairments, which can be influenced by several factors, as you can see here, such as biomechanical limitations, central movement disorders, sensory awareness, and fear. So if we take a look at the parameters that we have. So low values in directional control in the maximum or endpoint exclusion are indicative of limited range of motion, weakness, and other musculoskeletal deficiencies. In the case of low movement velocity, they are indicative of neuromuscular deficiencies caused by stroke, for example, Parkinson's, and other age-relative disorders. In the case of the low reaction times, they can be indicative of cognitive deficits, such as or fear of falling, and sometimes anxiety, often due to aging. Also, patients with acute symptoms of dizziness, they may be afraid to approach limits of stability, showing results with values outside the normative values for all parameters. On the other hand, results within the normative values are indicative of good voluntary motor control and adequate proprioception of the lower limbs, as well as the range of motion and strength for mobility. Here we have an example, staying in balance in the limits of stability, and when you are out, you will lose your balance and you need to do some strategy to avoid falling. So before finish the clinical considerations, I have here some articles that I would like to show you about this protocol. So in this first case, Clark and Rose conducted a study about the reliability of the 75% limits of stability test, in which they administered in 50 older adult scholars on 2 consecutive days, and they found that limits of stability provides consistent and reliable results. Also, there are some articles about the use of this protocol to help screening fall risk in elderly people. They were able to confirm statistical significant difference in the velocity movement and worse global scores for the group with falls. In addition, there have been some studies about the correlation between ankle strength and limits of stability, particularly the front-back maximum exclusion in this article, and at last in this one, Williams demonstrated that low values of directional control was one of the parameters that could help predict an ankle injury. So I leave these articles if you want to know a bit more about this protocol and the meaning of the parameters. And with this, I finish my presentation about this protocol. But before you leave, I would like to thank you for joining me today. It was a pleasure to share this know-how. It was a brief webinar, but if you have some questions, feel free to send me an email. You can send an email to Cláudia Tonelo at sensingfuture.pt. I will be happy to answer. And before you leave, if you have other questions about PhysioSensing, scientific advice, feel free to ask for a demonstration of PhysioSensing. I can show you the solutions that we have. And take a look at our blog in our website page with several articles that can be your interest. In here, we also have an article about limits of stability. You can have a look at it. And if you want a quotation, please go to our website request pricing page. And please note that we ship worldwide. We have distributors in 50 countries with local support. And before finish this webinar, I'd like to tell you some news that we have. So we will be at Medica this year. We will be exhibiting. So you can come and visit us. And here you can see for yourself all the products that we have in real time. We will be at Hall 4, stand E33. You can send me an email if you want to schedule an hour and we can demonstrate all the products. And also, I'd like to share with you our newest product. It is the PhysioSensing sensory motor testing platform. It is a bigger platform, more accurate and super complete. So it allows you to do different protocols. We have the balance protocols that are listed here in this slide. You can see that we have also limits of stability, the modified CAT-SIB, very known. And we have these new protocols, the step up over, that you need to have a step like this, a small box where the patient needs to step over the step platform, and we measure several parameters about dynamic balance like like limits of stability, and we also have the forward lunge, where the patient needs to lunge in the platform, and you have also more than 30 balance exercises that you can do. And again, we have all these protocols that you can use, and also the Podal software with static analysis, dynamic analysis, where you can walk over the platform, and also postural analysis. So before you leave, thank you again. And to finish, like always, we have here the date of our next webinar that will be about the sit-to-stand test, a very well-known test to quantify the ability of the patient to lift from a sitting position to a standing position. We will explain the protocol more in depth, similar to what we did today, with limits of stability. Closer to the date, we will open the registrations. Thank you again, and have a great day. Bye.